Hello, YouTube. This is Dr. Drew Srinivasachar, a fourth-year resident physician in internal medicine and pediatrics at WMED in Kalamazoo, Michigan, and an incoming pediatric hospital medicine, or PHM fellow, at the University of Nebraska Medical Center in Omaha, Nebraska. The following is a re-recording of a presentation given as my pediatric grand rounds on October 25th, 2024. I hope you enjoy. Today, I'm going to talk with you a little bit about some updates at the nexus/overlap of pediatric and adult inpatient care. A topic area that can be summed up with the question of whether or not these patients are big kids or little adults. First, some disclosures. I have no financial disclosures related to this talk. I am but a poor house officer, so any financial disclosures should be considered a red flag. However, I do have a declaration of interest. As previously mentioned, I am a combined internal medicine pediatrics or Med-Peds trainee, aspiring to combined adult/pediatric hospital medicine practice on completing training, which includes the PHM fellowship as previously mentioned. This perspective informs the content of this presentation. At the end of this presentation, I want to give you all three things to take away from all of this. First, I want you to be able to define the challenges we face at the overlap/nexus of pediatric and adult care, particularly for inpatient care. Second, I want you all to be able to identify methods for supporting pediatric to adult transition inpatient, including the use of a Med-Peds consult or inpatient service. And the last thing is to give you the tools to develop methods to address issues occurring at the overlap of pediatric and adult care, and/or that can be used by both pediatric and adult inpatient care teams, with consideration of available resources and the patient population you are treating. With that, let's talk about those challenges in adolescent and young adult inpatient care. There are two dimensions I typically see when it comes to this pediatric and adult overlap or nexus of care. The first, and the most obvious, is the pediatric to adult transition of care, specifically for children or adults with special healthcare needs. Now, for a lot of diseases, there's been a decent amount of work on this. For cystic fibrosis, the CF Foundation has guidelines on care of adult CF patients. For congenital heart disease, a whole subspecialty, adult congenital heart disease, or ACHD, was created to specifically care for these uniquely challenging patients. Patients with sickle cell disease and type 1 diabetes are commonly cared for on the adult side. However, they are often stigmatized due to the tendency for repeated admissions, and this stigma can affect their ability to make the transition between the pediatric and adult world. And there are other complex chronic congenital conditions that are taken care of by both the pediatric and the adult world, including intellectual disability and developmental delay, childhood-acquired HIV, inflammatory bowel disease, and so on and so forth. Then there's another less well-known dimension, and that's the sort of overlap, if you will, in care of adult patients on pediatric services and pediatric patients with traditionally adult conditions. These include things like adolescent and young adult hematology oncology, care for patients during the COVID surge, I'll discuss this in more detail later in this talk, and care for patients in the pediatric world who have classically adult conditions not typically seen in general peds. For example, venous thromboembolism, DVT, PE, heart failure, type 2 diabetes, and hypertension. Let's focus on that first population. Ideally, the pediatric to adult transition is an outpatient process. It's typically led by the PCP or an outpatient subspecialist. So a patient would be transitioning from care by a pediatric primary care doctor, a family medicine doctor, a Med-Peds primary care doctor, or a Peds subspecialist, and the transition would be to either family medicine, Med-Peds primary, internal medicine primary, or an IM subspecialist. There are 6 major steps that typically start at adolescence, and these steps correspond with 6 core elements of a successful transition. A clear transition policy typically gets discussed around the ages of 12 to 14. Transition tracking and monitoring typically occurs around the ages of 14 to 18, as does assessment of skills specifically for readiness to transition to adult care. Planning of the transition, including development of a healthcare treatment plan, including the medical summary of everything that has gone on during the pediatric phase of care, also typically occurs around the ages of 14 to 18. And then around the age of 18 to 21 is the transfer to adult-centered care, or integration of the patient into an adult practice, depending upon the nature of the care that was received in the pediatric phase. For instance, a pediatric patient going to an IM primary office, or PED subspecialty to IM subspecialty, or even a pediatric patient who is cared for by a Med-Peds primary staying with that Med-Peds doctor for their adult care, but transitioning into an adult mode of care. As soon as that's finished, there are steps to confirm that the transfer is complete and elicit feedback from all stakeholders, including the patient's family, and target decision makers, the physicians who are caring for that patient, and the healthcare system as a whole. And as I mentioned before, certain diseases have specific guidelines on transition. For example, cystic fibrosis. Though these guidelines have not been updated in the last 20 years, even with the rapid amount of progress that's been going on in that space specifically. But in reality, oftentimes patients with these conditions have multiple inpatient admissions, and they often do not or are unable to see their primary care physician regularly. Often the best opportunity to transition these patients to adult care is during an inpatient admission. Disparities exist in the transition of these patients. For instance, utilization of children's hospitals, readiness to transition to adult care, and so on and so forth. And frustratingly, the American Academy of Pediatrics does not give a clear answer regarding age limits for pediatric care. Quote, "The establishment of arbitrary age limits on pediatric care by healthcare providers should be discouraged. Healthcare insurers and other payers should not place limits that affect a patient's choice of care provider solely on the basis of age." Unquote. This tends to be problematic. And this population of patients who are aging out of pediatric care is growing with a growing cost. One of the earliest studies by Goodman et al., published in 2011, looked at data from 1999 to 2008. They found that adult patients admitted to children's hospitals accounted for about a 6.9% increase in inpatient discharges per annum, a 7.6% increase in inpatient days in the hospital, and 15% increase in inpatient cost. There was an increase in inpatient stay in patients with cystic fibrosis, malignancy, epilepsy, and cerebral palsy, but not for adult congenital heart disease or sickle cell disease. For costs, those are increased with malignancy, adult congenital heart disease, epilepsy, and cerebral palsy, but not cystic fibrosis or sickle cell disease. Some more recent data from Allen et al. Looked at numbers from 2004 to 2019, and they found that adults over the age of 18 made up about 4% of discharges from children's hospitals. And there was actually an increase in the growth in the number of these discharges in all age groups above the age of 18, but significantly in pages aged 21 to 25 years old. These patients had a higher proportion of complex chronic conditions, had increased length of stay, and increased total cost of inpatient stay. Boggs et al. In 2021 also looked specifically at this population, and found that there was an increasing proportion of these patients who had technology needs, things like feeding tubes, VP shunts, tracheostomies, and central lines, especially in patients aged 16 to 21. And then, very recently, this was just published within the last year, Dornbush et al. Looked at data from the Pediatric Health Information System, or PHYS database, from 2021 to 2022. And they found that there was an increasing cost of admission dose response with age. Compared to patients aged 0 to 18, there's a 13% increase in the cost of admission for patients aged 18 to 20, 25% increase for those aged 21 to 25, and a 72% increase for those aged 25 and above. So this is, again, a growing issue, and one that likely is not going away. And this population has growing disparities as well. Work by Jenkins, Langskron, and Auger, published in 2024, looked at the amount of pediatric hospital use among adolescents and young adults with 3 specific conditions in particular: sickle cell disease, cystic fibrosis, and congenital heart disease. They found that young adults with sickle cell disease, almost invariably Black patients, and Black young adults with cystic fibrosis and adult congenital heart disease had lower odds of being admitted to a pediatric hospital, which can affect the quality of care, particularly for those patients who are admitted to hospitals that don't have the experience in treating, for instance, cystic fibrosis and congenital heart disease. Young adults with sickle cell disease in rural areas were almost never admitted to pediatric hospitals, but young adults with cystic fibrosis in rural areas actually had increased pediatric hospital admissions. Again, this is probably due to lack of experience with caring for cystic fibrosis patients in hospitals that are small. And when looking at patients with sickle cell disease, the likelihood of pediatric hospital admission actually increased if the patients had private insurance and if their parents had higher income, likely because of parent coverage of the child up until the age of 26. if we look at this graph, there's a peak right about the age of 16 for pretty much all of these admissions. Then it goes down to 0 for sickle cell disease at the age of 23. There is a little blip for congenital heart disease at around the age of 22, up here, and then it peters out. And the same thing for cystic fibrosis. It steady states, as with all the other diseases, around the age of 23. As I mentioned before, hospitals and clinicians tend to be underprepared to care for these patients. Okamura et al. In 2008 did a survey specifically for primary care for patients with cystic fibrosis and sickle cell disease. While this is outpatient focused, it's instructive. They found that for cystic fibrosis, about 38% of pediatricians were comfortable with the primary care of these patients, but only 15% of internists were. Sickle cell disease is a bit closer, but again, only about 1/3 of both pediatricians and internists were comfortable with the primary care of these patients. Most internists, when asked why they were uncomfortable, thought that the primary care of these patients should be managed by adult subspecialists. Most pediatricians, on the other hand, feel that the primary care for these patients should be under pediatricians, regardless of whether or not they were generalists or subspecialists. Hunt and Sharma looked specifically in 2013 at hospitalist care for adults with complex chronic congenital conditions. They found that about 60% of hospitalists saw more than 5 adults with these conditions over a 6-month period. They found that 40% of internal medicine hospitalists were not comfortable with caring for these patients, versus 5% for Med-Peds trained hospitalists and 14% for family medicine trained hospitalists. In terms of barriers, they noted lack of familiarity with the literature, lack of training in complex chronic care and adolescent care, difficulties with subspecialist coordination, and difficulties with outpatient follow-up, which were factors that led to discomfort in caring for these patients. Again, this is old data, but anecdotally there is a decent amount of discomfort when the peds and adult worlds cross inpatient. So we talked about the classic pediatric to adult transition population. Then there's this other population, adults newly requiring pediatric care and pediatric patients with traditionally adult conditions. For that first set, specifically we're talking about adolescent and young adult HEMOC patients. These patients tend to be treated, because of increased survival when this is done, on pediatric protocols. Patients with ALL tend to be treated on pediatric protocols up to the age of about 30 to 40. In fact, increased survival has been seen up to about the age of 45. And AML is usually treated on pediatric protocols up to about the age of 30. And this is typically based on protocol eligibility. During the COVID surge, and again, we will talk in far more detail about this later, adult ICU and floor bed limitations led to the PICU and the PEDS floor taking young adult patients. We'll talk a little bit more about the Popcorn Network and the work that was done in terms of how it got pediatric docs familiarized with the care for adult patients. And then, with the pediatric/adolescent/young adult patients who have traditionally adult conditions, there are multiple things like venous thromboembolism, acute coronary syndrome, stroke, type 2 diabetes, hypertension, substance use disorders, pregnancy. All of these things get pediatric hospitalists out of their comfort zone when it comes to caring for these patients. Although I will say that pregnancy tends to get both peds and IM hospitalists out of their comfort zone. With all that said, how do we approach these patients? That leads me to my next topic, the Med-Peds inpatient and Med-Peds consult services. First thing, is this really a new idea? Not really. This is an early example of transition support. Burns et al. Wrote in 2017 about a type 1 diabetes youth support specialist service in Australia. They looked at a total of 55 DKA admissions amongst 39 patients over the course of the year 2011. They found that each of those patients were actually served by the youth support specialist service, and those who had that support service had lower length of stay and had less severe acidosis at presentation, indicating at least decently better control and decently earlier warning that something was wrong to get them to inpatient care. I will note that this is an outpatient-based service and isn't exactly an analog to the services that I am interested in talking about. But something that's a little bit closer of an analog is the hospital medicine adult care service at Cincinnati Children's Hospital. This service was described in 2015 by the two founders of the service, Drs. Ben Kinnear and Jen O'Toole, Med-Peds hospitalists at Cincy Children's and the University of Cincinnati. This is a consult service that is staffed by Med-Peds physicians where the specialty services remain primary, but HMAC, as it's abbreviated, is available to supply recommendations regarding care for traditionally adult conditions and also provide transition support. So, okay, we have a precedent for this. So what? What's the value? Why do we need this? We look to a study from Peterson et al. In 2023. Fun fact, Dr. Peterson is also now at the University of Cincinnati. They did a mixed methods exploratory study looking at the adult inpatient services at children's hospitals. These were semi-structured interviews. They looked at 10 institutions in the survey, all of which were freestanding hospitals. This is important because there are differences in how freestanding hospitals versus hospital-within-hospital children's hospitals work in this regard. Quantitatively, of the 9 institutions that they found that had these adult medicine services, they were all either admitting or consult services. All of them had Med-Peds physicians on staff, and of those hospitals, they did tend to set age limits, typically around the ages of 21 to 35, but there were exceptions. Adult congenital heart disease typically doesn't have an age limit. Adolescent and young adult hem-onc typically has age limits that are set by the eligibility for protocols. And low weight. Any patients who are less than 40 kilograms at most hospitals tend to still be admitted to peds because of the need for weight-based dosing. The most common diagnoses, complex chronic diagnoses, these patients had were neurodevelopmental disorders, adult congenital heart disease, metabolic and genetic disorders, which also used to be extremely life-limiting, and now these patients can survive well into adulthood, adolescent and young adult hem-onc, and pulmonary disorders, specifically cystic fibrosis. The most common utilizers of these services: pediatric cardiology, pediatric hospital medicine, peds hem-onc, the PICU, and peds pulm. Qualitatively, they look specifically at facilitating factors, barriers, and other considerations. The big things that facilitate the support of these consult or inpatient Med-Peds services: recognizing that there's a need for it, and having champions that advocate for the service. Specifically, institutions that want to have greater adaptability in all ages care of these adults with special health care needs, and the desire for these centers to be centers of excellence for that care. The other big thing, if you have Med-Peds physicians on service, these services tend to last longer and tend to do better. Big barriers? Funding, funding, funding. Always the biggest barrier in making sure that these services are able to stay solvent and able to do what they need to do. And we'll talk a little bit more about a case study from one of these services in a little bit in terms of how that service is funded. The other thing, too, is that there is the risk that there would be a change in support for the service with staff turnover, particularly for those folks who may not recognize the value of the service. The other considerations for the service, although it's not necessarily a barrier or facilitating factor, is whether or not these services were associated with a program that focuses on outpatient transition of care for these patients. So let's look at a case study, and this is specifically for a Med-Peds inpatient service. I have to thank Drs. Colby Feeney and Yasmin Marcantonio for doing this work. They had published data back in 2022 with a follow-up in 2023 about a dedicated inpatient service line for adults with special healthcare needs at Duke University Hospital that started in June of 2019 and had data that was analyzed through July of 2021. For reference, Duke Children's Hospital is what we call a hospital within a hospital model, i.e. it's a children's hospital wing within a larger adult hospital. This Med-Peds inpatient service was housed on the adult side, and it was staffed by Med-Peds trained hospitalists. The service was unique in that they performed a Transition Readiness Assessment Questionnaire, or TRAC, and Social Determinants of Health, or SDOH, screening as part of the admission process. They also looked specifically at coordinating outpatient transition with this service. There were several metrics that they were able to analyze. They looked at the first admission to the Med-Peds service and the number of admissions for each patient that they served. They looked at the disease type, specifically the complex chronic condition that these patients had that would indicate the value of being on the Med-Peds inpatient service. They looked at how many of these patients were able to complete their TRAC questionnaire and their SDOH screening. And, of course, other things like length of stay, 30-day readmission rates, and outpatient follow-up. The first part of the study looked at data up until December of 2020. In terms of demographics and transition readiness, most of the admissions, about 70% or so, occurred within the first 6 months of initiating the service. So basically from June of 2019 to December of 2019. In terms of demographics, about 56% of patients were Black, 58% were women, 70% lived greater than 15 miles from Duke University Hospital. Interestingly, 85% or so had a PCP on file, and about half, about 51% or so, did not have a prior admit within the last 2 years. The most common complex chronic condition of childhood? Well, 22% of these patients had sickle cell disease, 15% had type 1 diabetes, 11% had rheumatologic conditions, and 11% had inflammatory bowel disease. About 76% of patients that they had on the service were able to get their track questionnaire complete, mostly younger patients who had more admits. 48% were able to get their social determinants of health screen complete, and of those patients, about 2/3 had at least one unmet need, including food insecurity, transportation needs, and financial strain. And if we look at the track questionnaire, these are the subscales that they looked at for transition readiness, specifically regarding managing medications, appointment keeping with primary care and subspecialists, tracking of health issues, talking with providers, primary care and subspecialists, managing daily activities, and total. The track goes based on a Likert scale, where 1 means no, the patient does not know how to do anything regarding the specific task asked about. 2 being no, but they want to learn. 3 being no, they don't know how to do it, but they're learning how. 4 being yes, they know how to do it, and they've started doing the task. And 5 being yes, they started doing it and are consistently doing the task. As you can see here, in total, we're in approximately the 3 to 3.2-ish range. Most folks are learning how to do all the things needed to transition to adult care, and they're getting close to being able to start doing all of these tasks. The things that they are pretty good at doing are things like managing daily medications, talking with their doctors, and managing their daily activities. Appointment keeping, a little bit less so, and tracking health issues, a lot less so. But there's wide variability in all of this. Then if we look at specific admission details, like length of stay and outpatient follow-up for these patients, 254 patients had 385 admissions from July 2019 to December 2020. 82% of those patients were admitted from home or a non-healthcare facility. 13% were inter-hospital transfers. Fittingly, 82% of these patients were able to be discharged to home or self-care. And thankfully, only 3.9% of patients had to be discharged before medically indicated or against medical advice. The median length of stay for these patients was around 4.5 days. About half had stays less than 4 days, and about a quarter had stays that were greater than 7 days. So, interquartile range somewhere around 2.5 to 7-ish days or so. 90% of these patients had follow-up needs post-discharge. 62% were able to schedule a follow-up within 7 days post-discharge, and 50% of them attended follow-up within those 7 days. And this is important for those of you who are interested in billing/coding, clinical documentation integrity, and all that like myself, because this is a criterion for the high-complexity hospital discharge visit outpatient, the CPT code 99496. And these patients tend to be very complex. Thankfully, this increased to 89% and 75% respectively for follow-up 30 days post-discharge. And these patients had about a 20 to 21% 30-day readmission rate. Then they looked at follow-up data, extending the study out to July 2021, and they were able to get 323 patients now, 1,133 total admissions, to analyze. And these patients had similar demographics to the initial data for the Med-Peds inpatient service that they found in December of 2020. They also looked specifically at when these patients were admitted to other services. 77.6% were admitted to adult hospital medicine, 2.2% were admitted to PHM, 9% were admitted to surgery, 5.7% to subspecialty adult services, and 2.4% to subspecialty Peds services. These patients were more likely to be admitted to the Med-Peds service line if they were over 30 years old, had a PCP on file, i.e. they had contact with them, if they had multiple admissions in the last 24 months, essentially indicating that there was something that needed to be resolved in terms of their care, if they were non-emergent admissions and did not have an ICU requirement. If you're requiring ICU care, all this stuff goes out the window, and if they had complex chronic conditions of childhood other than sickle cell disease. If we go out to 2021, in terms of length of stay, that's comparable, typically 7 to 14 days of inpatient admission. Only 11 patients on the inpatient Med-Peds service line, 12 patients for other services, had stays that were 30 days or longer. In terms of 30-day readmission rates, stark difference. It was about 39% lower on the Med-Peds service, a hazard ratio of 0.61. The true number could be as high as 50% lower 30-day readmission rate, but even at the low end, a 25% lower readmission rate is still huge when it comes to these patients. In following up on this, again, thanks to Drs. Feeney and Marcantonio, I was graciously able to speak with them in July of 2024, and I asked them specifically about a couple of things that in these two studies were not specifically mentioned. In terms of big barriers to the service, the first thing was that this service tended to be used more as an adult hospital medicine overflow service because of the low population of appropriate patients. Adult overflow is almost inevitable if there are no appropriate Med-Peds patients admitted in-house. One of the big things is institutional buy-in. This service was funded through an internal clinical innovation grant at Duke, and that grant is not going to last forever. So one of the big things that they're looking at is, how do they fund this service for the long haul? They also found that if there's a lack of follow-up or lack of complexity in these patients, there tended to be non-utilization of the service and issues with transition to adult care not going well. And then there's the question about roles of care. For patients admitted to the Med-Peds inpatient service, is that service the primary service? Or were the subspecialists who were taking care of the patient's complex chronic conditions controlling the vast majority of care? Then they asked specifically about alternate methods. They actually started a consult line working along the same lines of the inpatient service in January of 2024. This provides consults for complex pediatric patients approaching adulthood or in the process of peds to adult transition, specifically for patients on surgical services and peds and adult subspecialty services. And they're looking at using similar methods to look at readiness for transition to exclusively adult care for these patients, but specifically with a consult model. With that, what other questions should we consider with regards to all this? Well, Collar et al. In 2020 did a survey of children's hospital leaders, so division directors, medical directors, and department chairs. They looked specifically at the feasibility of addressing specific transition items in patient. Things that were feasible? Mainly identifying patients overdue for transition, notifying them about the need to transition, and figuring out the timing of transition. Basically, the tracking and monitoring is the most feasible. The things that are the most difficult are peds provider and family interaction during the first non-pediatric stay, agreement on when the transition should be timed for inpatient care, consultations for child life, and care coordination between peds and adult subspecialists and providers. Essentially, the transfer completion activities were the ones that were found to be the least feasible. Of the outcome measures that these leaders found, the most important tended to track with how feasible they were to measure, naturally. And there tends to be greater feasibility on policy items and tracking and monitoring with centers that have a greater patient volume, i.e. academic centers, and greater feasibility in completing transfer completion items at institutions where adult and pediatric care is in proximity and where there's an established relationship, i.e. hospital within hospital models and those institutions that have an affiliated adult institution with them. So we talked about peds to adult transition. What about that other dimension? I mentioned the COVID surge and the popcorn network. 2020 to 2021 was bad for adult hospitals. COVID basically maxed out capacity, and so pediatric beds had to be used for adult overflow, and thankfully not many pediatric patients were being admitted at that time. However, pediatricians were being asked to care for adults. In response, a Med-Peds initiated collaborative known as the Pediatric Overflow Planning Contingency Response Network, or Popcorn Network, provided a space at the time to discuss methods for providing appropriate adult care in a pediatric setting and developing a comprehensive, feasible guide for care that intended to have some staying power. Big challenges that they found were system readiness, particularly with regard to ICU care, tracking of patients who were adults who were admitted to children's hospitals, scope of practice for categorical PEDS trained physicians and advanced practice providers, as well as staffing, particularly for Med-Peds physicians who were typically being asked to cover adult services because of the need there. Also, a challenge was just a general lack of awareness of patient safety issues on the adult side that just don't tend to be things that are minded on the pediatric side. Things like VTE prophylaxis, fall precautions, and behavior concerns. Although these things are now becoming a lot more common on the PEDS side nowadays. Some of the big recommendations that they had were basically making explicit but flexible admission criteria for these children's hospitals, soliciting regular feedback from stakeholders, essentially more communication, and more just-in-time resources to address problems as they came up. Interestingly, the reverse, adult hospital medicine being asked to care for older pediatric patients, particularly when PEDS had their surge, didn't appear to happen often, if at all. One wonders why. Then there's the whole thing of treating adults like the big kids that they kind of are. Again, much thanks to Drs. Rachel Peterson, Vig Doraiswamy, and several others who wrote earlier this year on a Med-Peds perspective on multiple interventions in the pediatric world that I think, and they think, would be beneficial on the adult side. Things like young adult or elder life, analogous to the child life services that we have in most hospitals, who reduce anxiety with procedures, help with pain management and coping, and use play therapy to help patients cope with being in the hospital, which often tends to be one of the worst experiences in a patient's life. Things like patient and family-centered rounding, multidisciplinary rounding, and family care conferences. These are being emphasized in the PEDS world, and now they're starting to be a little bit more of a thing in the adult world as well. The idea of safely doing less, i.e. minimizing unnecessary labs, vitals, and tests, and specifically limiting the amount of times you're interrupting sleep to do these tests, including minimizing the amount of overnight vitals, minimizing or changing the timing of labs so that they don't occur at 4 a.m. every single day, rounding at times where patients are awake and not at 6 a.m. These are ideas that we thought would be obvious, but for traditional reasons, we just haven't made changes. And things like multimodal pain control for use with blood draws, IV placement, and other procedures, through the use of things like lidocaine cream, ethyl chloride cold spray, and devices like the Buzzy Bee, which is used in the pediatric oncology world. All of which we do because we care about minimizing the amount of trauma that we do to kids when they're admitted to the hospital. Yet we don't think about the same for adults. All of this can be done, even in the ICU. Even at a small, quasi-community hospital like Bronson Methodist in Kalamazoo, Michigan. Thanks to Natalie Washburn, one of the pharmacists at the Bronson ICU, who graciously shared some of the preliminary data that Bronson obtained after implementing standardized multidiscipline rounding in the adult ICU. This method basically defined information dissemination roles, and it showed increased multidiscipline participation, more efficient rounds, and improved clinical metrics, including mortality, PT and OT utilization, and decreases in duration of indwelling Foley and central lines. And this method has family involvement integrated. Though this has been previously limited due to COVID, it's starting to become more of a thing now. So where does that leave us? What are my final thoughts on this? First, we need to acknowledge the fact that children with special healthcare needs become adults with special healthcare needs. The terms pediatric and adult for certain conditions are oversimplifications now. Second, we need to increase the utilization of Med-Peds trained physicians in the care of children and adults with special healthcare needs, including the development of Med-Peds consult and inpatient services where possible. And who knows, maybe more Med-Peds residents and more Med-Peds residencies. Third, we need to increase education, and not just for Med-Peds trained physicians, on conditions across the age spectrum, specifically for categorical Peds and IM residents and for APPs in Peds and IM. And we need to increase exposure in pediatrics for FM training. This is something with the changes to the ACGME guidelines for family medicine and Peds is something that is sorely needed, and I think was sadly not considered at the time that these changes were made. We also need to increase tracking of transition metrics, social determinants of health, and need to increase the amount of research that we do for adults with special healthcare needs to influence timely guideline development and updates. Again, the cystic fibrosis adult care guidelines have not been updated for the last 2 decades, even though we have medications now that are basically allowing these patients to live to a life expectancy of someone who doesn't have cystic fibrosis. And finally, we need to be able to translate the best practices from Peds to adults and from adults to Peds, especially the interventions or minimizations of interventions that we do. With that, I'd like to acknowledge several folks for this presentation. First, thank you to Drs. Theo Gomes and Nick Helmstetter, my program director and associate program director at WMED Internal Medicine and Pediatrics, for supporting me these last 4 years as I grew from a wide-eyed intern who maybe was a little bit too cavalier and brash to a senior house officer who is now matched and ready to enter PHM fellowship. Second, to Drs. Colby Feeney and Yasmin Marcantonio at Duke University for their gracious generosity and their time and insight regarding the work that they did on the Med-Peds inpatient and consult lines at Duke, and being willing to have an interview with my lowly self. Third, to the entire hospitalist community, from adult hospital medicine to PHM to Med-Peds combined HM, for welcoming me into their community with open arms and guiding me to my current path of becoming an academic combined hospitalist. Fourth, to all my co-residents, past and present, from Med-Peds, internal medicine, and Peds, for being there when the inpatient census ballooned, when difficult situations arose, and for all the sage advice from everyone, both senior and junior, and your collective support as we work to make things better for all. And finally, to my family and friends, for reminding me that there is a life outside of medicine, that wellness is paramount to a successful career, and that the things we do as physicians really do matter. And that's everything. Here are my references for all this. And more references. And I am happy to take any questions in the comments. Thanks for watching.